Yeah, I think we are live.
Yeah.
Good evening, everyone. So today's topic is on stimulation protocols using mild stimulations. And this topic is very useful for people in low resource settings and also for people who are challenged in terms of like multiple attempts and who want to try out low or milder stimulation protocols. And for people who want to again like not do the complete IVF but still want to do a IVF to give that benefit for patients who are like normal responders, or sometimes we don't find any reason where we need to stimulate them with our regular or routine protocols. So this has been requested by many people, especially from tier 2 cities and tier 3 cities, who want to do it because of the economical population that they cater to. And this was, in fact, Dr. Jay's idea to do this topic. Over to you, sir. You can start.
Yeah. So I will just go to the screen sharing. Okay. See, whenever we are trying to talk of mild stimulation protocol, okay, please remember it has not become a very popular protocol. Okay, because it is actually a protocol in between nothing and nowhere. Okay, you can't really standardize this protocol to everyone. There are lots of things which don't fit right into the mild stimulation protocol. So what is important to understand that when people try to say that, oh, they are mild stimulation protocol super specialist, it is actually not going to make any type of sense to anybody. Okay, because mild stimulation protocol should be actually used very mildly. It should be used basically sparingly. You should not be using this protocol for all the patients. In fact, if you want to note down some criteria, there can be these type of criterias. Normally we say antral follicle counts. If they are less than 6, they are poor responders. If they are more than 15, then they are hyper responders. But antral follicle count between 6 to 8. Okay. So this is that borderline low AMH types. Okay. Borderline low AMH category. Okay, this is also a protocol which you can use only if you are planning to do fresh transfers. See, if you are planning to do frozen transfers, then the endometrium does not really matter. It is absolutely a no-brainer. Okay, this is not to be used in frozen cycles. In frozen cycles, you use the standard dosages, no problem at all. This should be used in patients who are basically fresh transfer and then again international patients because they need to get out of the country. Okay, see, there is one theory which we must try and understand. Why does our ovary produce only one egg in a menstrual cycle? Okay, the reason why this ovary produces a single follicle out of the multiple small follicles which gets recruited, the dominant follicle, and then it forms a single follicle which is worthy of ovulation. It is because it is this oocyte which is present inside this follicle, it receives the best amount of vascularity. So it receives the best amount of oxygenation. As a result of this, the possibility that this will give rise to the formation of a euploid embryo, okay, is very high. Okay, as a result of this, it is nature's way of ensuring one that we form one embryo, but it is a euploid embryo, and that euploid embryo gives rise to a healthy pregnancy because majority of the pregnancies which occur naturally are pregnancies which are similar to having a single blastocyst transfer. Correct, no? So this single blastocyst euploid transfer is the concept of actually doing the mild protocol. Thinking that if I do the mild protocol and let's say if I'm able to get approximately 5 oocytes, I will be able to ensure that these 5 oocytes, all of them have got adequate oxygenation and all of them would give rise to euploid embryos and all of them would increase the success rate because your ultimate success rate is going to be driven by this euploid embryo and not by the maximum number of embryos. So this is the basic concept. So apart from these international patients, in an Indian scenario, you can also extrapolate this to medical disorders. And these medical disorders are going to be predominantly patients who are having renal and autoimmune disorders. Okay. These two are the conditions, but the most important condition is still condition number one, where antral follicle count is between 6 to 8. So please keep that in mind. Okay, one cannot really think, or one cannot really end up doing things by using a mild stimulation protocol when the antral follicle count is 10. If in case you do that, then you will end up with an iatrogenic poor response. All right, fine. So what should be your protocol? Okay, again, the best way to use a mild protocol is by simply standardizing it. So how do you standardize it? You know that we have this protocol of letrozole 2.5 plus highly purified HMG 150 international units, which we use when we want to do a natural intercourse or an IUI cycle, which we use for 7 days. Now, when you want to switch this protocol to IVF, which is a mild stimulation protocol, okay, in the IVF protocol, all you need to do is give it for 9 days. So, these 9 days may, the first 5 days is going to be HPHMG plus 150, and the next 3 to 4 days is going to be HPHMG plus antagonist. Okay, so that completes your 9 days. After this, if in case, okay, so this is your 9 days finished. If in case you are doing a fresh transfer, which should be the indication, then the trigger, as always, is going to be with 10,000 HCG. And usually, with this type of a stimulation protocol, you will end up securing approximately 5 to 6 metaphase to oocytes, provided you stick to this criteria. That is criteria number one, which is very, very, very important. Remember, there could be certain occasions which are other additional criteria, and I will add this because this also is very, very important, that the patient should have a normal BMI. This dose of 150 will not work very nicely if the patient is obese. And also, please try and understand, keep the age of the patients restricted to less than 40 years, because if you are restricting, I mean, if you are taking more than 40 years, then you will not be able to get a suitable response out of it. Okay, the luteal phase support in the mild stimulation protocol is just going to be absolutely standard, and that is going to be just giving progesterone gel 8% twice in a day along with estradiol valerate, because you are going to be using a fresh transfer cycle for all these patients. Okay, fine. Which are the conditions which you are supposed to avoid the mild stimulation protocol? Remember, any other condition apart from this criteria which has been mentioned, do not do a mild stimulation protocol. Never try to go into a mild stimulation protocol when you want to freeze these oocytes. It has got absolutely no role of trying anything like this. So just don't try it. This is only and only for patients who want fresh transfer, only and only for patients who have an antral follicle count between 6 to 8, preferably age less than 40, preferably age between 33 to 40, not less than 33. Less than 33, go ahead with the full 300 international unit protocol, and preferably women with a normal BFI. Please, one more thing you should ensure, this is not going to be your standard practice, because in your standard practice, in order to ensure that your mild stimulation is working very well, you need an excellent embryology laboratory. You need to ensure that these 5 to 6 oocytes which you are getting are treated extremely well. You need to have excellent trigger conditions. The 5 to 6 which you obtain should be metaphase 2 oocytes. It should not be that, these 5 to 6 means there is 2 are M2 and 3 are GV. Okay, then tumhare lag gaye. Nothing is going to happen in that particular situation. This is a protocol which can also be extrapolated in the modern day scenario of India for the donor program. For people who are using the donor program, this can be extrapolated to them as well, because the restriction limit which we have is to get 7 oocytes. Okay. So ideal stimulation as experts, which we keep on doing and we all keep on bragging that we are experts, is that to get 7 oocytes. Okay. So if in case you really want to do 7 oocytes, then this is something which is important, which you have to keep in mind. Apart from this, I practically think this is not a protocol in which you should give too much more attention to. Don't try and micro calculate the dose. There are enough papers who have shown that if you standardize the dose at this thing, okay, it is more than enough. Okay, more than enough. Just instead of natural intercourse where you are giving 7 days, add 2 more days. In natural intercourse, you will not give antagonist, or at max, you will give half dose antagonist. Here, you will give the standard 4 days of antagonist because you want to avoid an LH surge. Apart from that, there is no rocket science involved in this. And remember, this also gives you a decent success rate. So the live birth rate following a mild stimulation protocol is going to be around 30-35%. This is all predominantly for self cycle patients. This has got no role, okay, when AMH is 0.4. This has got no role when AMH is 9.3. Okay, all this is no role. Antral follicle count between 6 to 8. If it is 10, don't use this protocol. Very simple. Okay, because remember, this protocol will give you any which ways 5 to 6 eggs. And the patient's antral follicle count is between 5 to 7. Okay. If the antral follicle count is 15 and you are using a mild stimulation protocol, that means you are causing an iatrogenic poor response. So don't do that, please. Okay. Keep that in your mind. Don't do this. I do understand that there is a beautiful fan club and fancy, okay, in between patients. When you tell them I'm going to doing mild stimulation IVF, oh, they only feel, oh, very good, very good. Mild stimulation IVF means excellent, 95% success rate. Okay. Nothing like that. After one cycle, that patient will give you 1 star on Google review and get out of your clinic and go to somebody else. Okay. This is practical life situation. It is easy to fool some patients. It is not going to help you fool all the patients. Okay. So please keep that in mind. And it is a big hit in conferences, especially when people are drunk and meet each other. No, everybody is a mild stimulation specialist. Okay. Just remember that doesn't really work in practical life situations. Don't cross these boundaries for such protocols because these protocols are for special purpose protocols. See, remember, if it was so good, the whole world would have shifted to mild stimulation protocol. It is like how we can make a joke of IVF clinics in India. If Indian IVF clinics are genuinely given 75% success rate, why will anybody do IVF in Dubai? Why will anybody do IVF in Thailand? They are mad or what? Flight ticket to India is so cheap for those countries. Everybody will come to India only. But it is reverse, no? Indians are going to Dubai and Thailand and getting their IVF done. So you have to treat all these things with a pinch of salt. People who think they are in low resource settings, let me tell you, the cost difference between using 150 international units for 9 days and cost difference for using 3000 international units for 9 days. Standard drug rates, okay, not the MRP which people charge. Standard drug at which drugs are delivered to your clinic is not even going to be 5,000 rupees. Okay, because HMG is not very expensive in India. So please keep all these things in mind when people message, no, oh, my patient cannot afford HMG. But if your patient cannot afford HMG, why are you doing IVF? Simple. Understanding? So please keep these things in mind before you do these protocols. I think I'll answer maybe one question or two questions from Shilpa madam before we finish.
Yeah. So what is your take? See, if you have already started stimulation for IUI or the natural intercourse, and you want to convert it into IVF because you see on day 8 when you do a scan that there are more than 4 follicles. So can you just add an antag during that time? I mean, not exactly on after 5 day on 5th day of stimulation.
It's possible to add, madam. But then again, it is not going to give you a desired outcome because what will happen is the recruitment would have already occurred. So in that day, when you add an antag, you might get, let's say you are seeing 10 follicles which are that size, you will get only 6 oocytes.
Mm. So you didn't mention about the siphon protocol or people who start with stimulation for IUI and suddenly they see. What is your thought on this converting these IUIs to IVFs? I mean, do you believe in it? Do you do it practically, or you think, I mean, all IVF should be started as IVF and should end as IVF, and IUI should only end as IUIs?
It's a very gray area. Okay. It depends upon the response of the patient to that IUI stimulation. But I think in our unit, the conversion rate from IUI to IVF is less than 1 in a year.
Really?
Yeah, really. It is less than 1 in a year.
But
Check
for
our statistics.
no, but for PCO and all, you're giving like 150 IU of HMG
But
and
madam, it will be 4 5 follicles. They will not end up giving 25 follicles.
really, I mean,
Yeah.
say like, 8, 9 in like one of cases among, say, 20, 25.
Yeah, it's okay. Yeah. Do IUI for them. Nothing happens.
Okay, so in this set of population that you are doing between 33 through 40 and mild IVF stimulation, so is it like a first choice, or is it like they have tried 2, 3 times and then, or is it like based on the transfer that you decide on the?
We never counsel anybody for mild IVF. The only patient who gets counseled for mild IVF is somebody who is an international patient and wants to go back to their country within that 15-20 days range. Okay. And antral follicle count is between 6 to 8. So in the whole year, we will not do more than 10 patients with mild IVF stimulation. Whole year.
So this is the other way around, right? I mean, you're not stimulating for this thing, like you're choosing the stimulation protocol only because you want to do a fresh transfer and nothing
Correct.
else. That's
Correct.
the basis of this whole.
Absolutely. If I want to do frozen cycle,
Mm.
I am not going to be falling for all these things. If it is FET, I will give standard dose. No changes in the dose. Okay. I might get 1 or 2 extra follicles also in that situation. And it may affect the endometrium, but that is okay for that particular cycle, no?
No, but see, I mean, antag also, like I think we were discussing sometimes in some other class. So you said antag should not be used in fresh ET cycles, like when we discussed about giving it for PCO patients or some other patients. Like, so you said strictly like antag shouldn't be used, but now here
Correct.
your antag should be used. So for fresh transfers, so what is your funda that we can use it?
No, I have always said that even if you are doing fresh cycles, you can use an ANTAC protocol or you can use a long protocol and both will give you the same outcomes. The problem of using ANTAG is in natural stimulated cycles. Because in natural stimulated cycles, what typically happens, the more ANTAG you end up giving, the less responsive the endometrium is because the estrogen peak, okay, is very, very mild. So that much receptivity is required for that estrogen. Correct. Beyond this, madam, okay, beyond this, all that things which we try to talk about for a fresh cycle with antag is secondary, because in natural cycles only we are giving half dose. Otherwise, we don't give antagonist in natural cycles. That peak of estrogen is very important, and that much only amount of peak of estrogen is there. So we don't want to suppress it with antagonist.
Mhm. So, in these cycles, like mild stimulation where you do FET, so post-transfer, do you add estrogen?
Yeah, I said we'll add estradiol valerate.
Okay, okay. So estrogen, progesterone is what you pick. Okay, yeah. I think okay. So apart from these indication that you said, and you see sometimes it becomes very popular among people who want to do it because they don't have the freezing program so robust, or they don't want to uh, kind of like, I mean, I know you don't believe in fresh transfers, but I think there is definitely a role for fresh transfers if at all, I mean, whatever the criteria that we want to adopt. But you still think that mild stimulation for Indian scenario is still not great, because there are so many IVF centers which are popping in these tier 2, tier 3 cities, which are catering to not the economical aspect of it, but lack of the embryologist, lack of the great freezing system. Don't you think like we should adopt this more to give that advantage of doing an IVF? But at the same time, like, not actually having the entire basket of services that an advanced IVF clinic should have.
Mm. I don't think all that is right to discuss, madam. Because if you are starting an IVF unit without having a proper embryology backup, it is not a good thing. I don't think it is a good thing.
Okay. Yeah, sure.
I mean, tier 2, tier 4, whatever it is. See, IVF centers are going to come up in every city. Forget tier 1, tier 2. Okay. It is going to come up in every city. And slowly and steadily, these centers will increase their proficiency.
Yeah. Yeah.
100%. I mean, it is just a matter of 2 years. Embryologists will crop up everywhere. Efficiency will go up, and even they will have full-time embryologist. That phase is gone, Shilpa madam. Tier 2 centers not having a good embryologist. I was just speaking to one patient in Meerut today. Okay. Meerut is a small city. Okay. And a small city like Meerut is having 5 or 7 IVF centers. I'm sure Bangalore must be having 100, Bombay having 150, 200. So it's all going to catch up sooner or later.
No, but see, I mean, see now the packaging that they are doing, like, I mean, one embryo transfer with one OPU with the drugs and all. If you are catering for, like, say, 70,000 to
Mm,
80,000, so how
mm.
will they be able to do a freeze and do all? So isn't that
Madam, all these people have some hidden cost here or there. So they make up. We should not be worried about such practices. They make up for their hidden cost. I know of an IVF center which charges 10,000 rupees for HCG 10,000 and 5,000 rupees for HCG 5,000.
really?
Yeah.
Okay. Great. So,
It's a special injection, temperature sensitive, to be taken in the clinic only. And this will get empty follicles.
oh, great. This is
Yeah.
okay.
So they all make up, madam. See, there are people, even if there is an advertisement on Google which says IVF is done for free, no patient still pays 1 lakh. Semen analysis is 7,000, AMH is 12,000, something like that.
Hmm.
Patients end up paying.
Yeah, I agree. Yeah, okay. Thank you. But this was a good topic. I know, I think, I don't know. I think we should figure a way where we can use this more often if it is going to be helpful, since
But
there is,
then these are the criteria. Do not try to push the criteria beyond this.
yeah.
The commonest question we get is, uh, antral follicle count is 12. Can I use mild stimulation? Why? I mean, when God is giving you 12 eggs, why do you want 4? You know,
Mm.
and then you are saying you want to do IVF. Okay. And then you are expressing the risk of OHSS. When you give a luprite trigger or when you give a decapeptyl trigger, how will you get OHSS? Even if you want, you will not get. Correct? So
No,
then
no.
where is the point?
At 1 legs, instead of that, if they get 4, that is what they want. They want only 4 because they don't know what to do with the rest 8, because they don't have the freezing program, which may be very difficult for you to understand. There may be, like, a lot of centers who are struggling, who have traveling embryologists, who have what do you say, freelancing embryologists who are coming in and they don't believe in freezing as yet. So they want to do fresh transfers and see if the results are going to be the same. I don't think we should actually, like, push this the protocol aside and say that it's not useful at all.
I don't know. I don't want to comment on it.
Yeah, sure. Yeah. Thank you everyone for joining us. Uh, we'll again see you sometime this week